My name is Mark Benson. I'm a preventive cardiologist at Beth Israel Deaconess Medical Center. And I was lucky enough to be part of the planning committee here at the 2024 American Diabetes Association Scientific Sessions. I'm highlighting a series of talks that really looked at pre-specified analyses from the SELECT trial. And so there were several takeaways. The two kind of overarching ideas here, again, in these pre-specified analyses, is what can we learn from the SELECT trial about the effects of semaglutide in patients who have pre-existing cardiovascular disease and overweight or obesity with BMIs over 27, but they don't have type 2 diabetes. And the second big kind of series of questions that these analyses tried to evaluate were, can we figure out anything about the potential mechanisms that underlie the cardiovascular benefit of semaglutide that we saw in SELECT? Is this from weight change, from hemoglobin A1C change? What were driving the cardiovascular benefits of semaglutide? In the first talk, the first analysis was really aimed at answering the question, what are the effects of semaglutide on glycemia in this patient population with pre-existing cardiovascular disease and BMIs over 27? And what the analysis showed was that semaglutide reduced the progression of glycemia and improved the regression back to normal glycemia in this patient population. And so really the takeaway that we can take to our clinical practice is that we can feel confident that we should expect improvements in the progression to diabetes and the progression in normal glycemia with semaglutide in this patient population. The second analysis looked at what can we glean in terms of heart failure outcomes and inflammation outcomes in this patient population. And I think there are a couple big takeaways. One of the takeaways was that it turned out 25% of the participants of SELECT had heart failure at baseline. About half of them had heart failure with preserved ejection fraction, and about a third had heart failure with reduced ejection fraction, with the remainder having unspecified types of heart failure. And what the analyses showed is that in this patient population who had heart failure, semaglutide reduced 3-point MACE and reduced a heart failure composite in this patient population. So I think the clinical takeaway that we can all feel confident about from this trial is that we can expect cardiovascular benefit in patients with ASCVD and BMIs above 27, regardless of a patient's heart failure history. And I'll just note that there was no difference in safety outcomes in whether you had heart failure or didn't have heart failure, whether you had heart failure with preserved or reduced ejection fraction. Another fascinating takeaway was from an analysis that was specifically asking the question, what can we learn about potential mechanisms that underlie the cardiovascular benefit of semaglutide in this patient population? And in this fascinating analysis, what was found is that the cardiovascular benefit of semaglutide in patients with pre-existing cardiovascular disease and BMIs above 27 were present regardless of baseline weight, regardless of weight change over the period of the study, regardless of baseline A1C or change in A1C over the period of the study. I think this is an important observation, and I think the takeaway that we can all take to our clinical practice is that we should feel confident and expect cardiovascular benefit of semaglutide in this patient population, regardless if the patient has significant weight change or has a significant change in their A1C on the medication. An overarching takeaway from SELECT is that these analyses are really building on the observations, of course, that we saw in SELECT, but also in SUSTAIN 6. that we are now seeing benefit of semaglutide in patients with pre-existing cardiovascular disease and diabetes and sustained 6, and now without diabetes but overweight and obesity. As preventive cardiologists, semaglutide and likely the rest of the class are really going to be important to think about in terms of preventive cardiovascular therapies and with their ability to prevent secondary prevention of cardiovascular outcomes. Health equity is going to be a key question to address based on the results of these analyses. It's been noted that 70% of the study participants in SELECT were male and 80% were of white ethnicity. And so expanding the generalizability of these findings to other populations is going to be absolutely key. And it's going to be crucial in terms of ensuring equitable access to these medications. For more information on these trials and more resources, definitely visit No Diabetes by Heart website. Also note that these excellent sessions were live streamed and several of them were simultaneously published in Diabetes Care.